Trachoma is the world's leading cause of infectious blindness, with its highest burden in Africa. Trachoma is caused by infection of the bacterium Chlamydia trachomatis, resulting in active disease where the inside of the eyelid becomes inflamed and follicles made from immune cells become visible. Active disease mostly affects young children, but as time goes on, repeated infections can result in scarring and the eyelashes become drawn in, scratching the eyeball. 1.9 million people are thought to have irreversible vision impairment as a result of this, a huge cost both to health and the economy in often the poorest areas of the world. If caught early, treatment with azithromycin can prevent these complications, but accurately diagnosing trachoma is a major challenge based on subjective examination of the eye by trained staff. To be diagnosed with follicular trachomatous inflammation, for example, a patient must have 5 or more follicles with a diameter of ½ millimetre. Understandably, disagreement between what does and doesn't pass the threshold is common. For example, a previous study found an inter-observer kappa of only 0.55 photographic grading based on follicles. It is also difficult to know from examination whether a participant is at risk of going on to develop complications like scarring or blindness. We need an objective, cost-effective diagnostic and screening tool to identify those most at risk. To address this problem, we propose using artificial intelligence to objectively classify participants into clinical categories and predict their likelihood of going on to develop scarring and blindness. We will use 2 types of images for this. Digital photographs of the averted upper eyelids, showing their visible clinical symptoms, and images of the conjunctiva taken by in vivo confocal microscopy, a really exciting, non-invasive technique allowing us to detect changes at the microscopic level, such as the influx of immune cells or changes in tissue organisation that could be an early marker of scarring. We have thousands of photos taken from participants in the Gambia, in Tanzania, Ethiopia and the Solomon Islands, and hundreds of microscopy images taken from participants in Tanzania. These participants have been graded either by experienced trachoma physicians, nurses or trained examiners, and for many, we have detailed follow-up data on whether they went on to develop scarring or blindness. We will take 80% of the photos and microscopy images and use them to each train a neural network how to recognise images from each category. Neural networks are systems designed to replicate the network of neurons in the brain, using examples to find patterns in images or datasets. For example, having been told which photos are from those who went on to develop complications, it will infer the rules for recognising those most at risk. Neural networks have already been found to have a comparable accuracy to physicians in diagnosing diabetic retinopathy, and have the potential to pick up patterns that even trained humans are unable to recognise. We'll build our model using Keras, a deep learning API for TensorFlow written in Python. Then we will test out its accuracy on the remaining 20% of images held back. If the model is accurate, it could be used to classify new images, giving an objective, cost-effective diagnosis, and giving the likelihood of going on to develop complications. It could even be implemented as an application, allowing users to take a photo on their phones, upload the image, and find out the diagnosis and prognosis. This will mean more objective diagnosis and prognosis without trained clinical staff, and therefore allow early treatment, preventing complications and lowering the number of years lost to disability. It will also allow more cost-effective surveys, allowing international eye care programs to prioritise mass drug administration to certain areas and reach the goal of eliminating trachoma. This will be particularly important in countries with a high burden despite interventions, such as Ethiopia, as well as countries with a high rate of active disease but low rates of detectable infection, such as in the Solomon Islands. As a team, we are uniquely placed to address this problem with our collective expertise in trachoma, in data analysis and in machine learning. We also have access to thousands of images, which is an incredible resource, as well as collaborators at the International Centre for Eye Health, Tropical Data Initiative and Peak Vision.